So let's talk about diseases of the arteries, and one of the most common diseases is hypertension. And hypertension is a chronic disease, slow developing, and as the nicknamed, a silent killer, because patient may not experience any symptoms while developing hypertension. And it also may be related to development of cerebrovascular, cardiovascular, arteriosclerotic, and kidney disease. Certainly this is a leading cause of stroke, hypertensive stroke, and heart failure, and it's preventable and treatable. When we're talking about hypertension, we have to distinguish between primary or essential and non-essential. Primary hypertension is really no certain cause knowing why this is happening. It's idiopathic with gradual onset, and another again name is essential hypertension. JNC guidelines important to know, and these are published in this link. If you click, you can find it and review it. And essentially what we want you to know, the parameters of hypertension evaluation as well as treatment. Risk factors for hypertension. There are numerous risk factors, and of course smoking, arteriosclerotic disease, and obesity, sedentary lifestyle, lack of exercise, and there are other numerous risk factors. However, one of the common risk factors is heredity as well as age, and age is explained very simply. Age influence on hypertension, because with age the elasticity and ability of the vessels to adapt to higher volume of the blood decreases, which results in increased pressure of the blood. Again, hypertension may be treated by lifestyle changes. Decreasing the sodium chloride or table salt intake may lead to tremendous results in your patients with no absolutely financial expense from them, as well as pharmaceuticals. Again, JNC7 will guide you through pharmaceutical treatment of hypertension at this time, and will guide you through the classes. And this is not the focus of this course, but in your pharmacology course you certainly will be exposed to the algorithms that you need to know to treat hypertension. Arteriosclerosis and atherosclerosis is a disease of loss of elasticity and thickening of artery wall or hardening of the wall. The component of this is development of fibrous plaque, which consists of fatty and lipid materials in the wall of artery. In arteriosclerosis, the vessels that affected are coronary arteries, cerebral arteries, and aorta and peripheral arteries. So what's the danger with atherosclerosis? That first of all, the capacity to pass more blood is decreases. However, the main problem here that the arteriosclerotic plaque may rupture and cause adverse events such as myocardial infarction and or stroke. Atherosclerosis, again, there are two major categories: controllable or non-controllable factor. Of course, heredity, age, sex, and history of diabetes are non-controllable factor. On the other hand, diabetes may be certainly modified and lead to lesser risk of arteriosclerosis development. Controllable factors: diet, introduction of exercise, reduction of stress. Again, cigarette smoking and hypertension also can contribute to atherosclerosis. So again, you may spend a couple of more minutes with your patient trying to introduce the importance of modification of controllable factors, and try to do it before an adverse event occurred versus after. Atherosclerosis diagnosis, of course, the best way will be the imaging study, such as arteriogram and Doppler. However, even increase in blood pressure may be suggestive of atherosclerosis. If atherosclerosis is becoming advanced and patient is experiencing stable or angina or unstable angina, CABG surgery may be indicated, and basically the occluded arteries will be removed and replaced, and plaque may be also plaque will be removed with that. And another option is the angioplasty without actual removal of the arteries and performed via cardiac cath. Peripheral vascular disease is certainly a condition can impair the circulation and certainly may be a big hinder on someone's quality of life. And intermittent claudication is one of the hallmarks of the disease, and muscle cramps or cramps, leg pain, lower like calf pain that occurs with activity, with walking, and relieved with rest, can be mistakenly described or named by the patient as arthritis even. However, if it's muscle cramp or muscle pain with walking, and which is relieved by activity which is relieved by rest, it may be indicative of PVD. So here the arteriosclerotic plaque in arteries supplying blood to legs, and the treatment may include a bypass as well as just angioplasty. But however, this can be fairly complicated and sometimes life-threatening condition and needs to be addressed. Peripheral vascular disease treatment includes endarterectomy, basically cleaning the affected vessel, and it needs to be done relatively urgently, because if the complete occlusion of the vessel occurs, patient may start losing the tissues secondary to necrosis, and amputation may be necessary, such as usually when necrosis occurs, it's painless. The affected extremity or toes do not have obviously sensation, and some nurses, not only novice nurses, but maybe very maybe imagining and thinking that this is a very painful condition for a patient, but however, at this point when necrosis occurred, there is really no pain. Pain fairly good symptom in this situation that may be indicative that treatment still may be helpful, as well as treatment is indicative. Aneurysms is a result of the weakening of the wall of artery and maybe leading to bulge or rupture. And aneurysms are asymptomatic. They are maybe something like a bruit, or some aneurysm may be palpated, and abdominal aortic aneurysm may be palpated on a very thin individual. However, you guys remember from very beginners courses that palpating abdominal pulsating mass is contraindicated. You certainly do not want to do it because of the risk of rupture. And if there is an abdominal palpating mass, you certainly want to avoid, and the next step in your diagnostic will be ultrasound to see what it is. Is it aneurysm or something else? Aneurysm need to be repaired before rupture, and usually the treatment successful. If rupture occurred, the treatment is almost impossible to perform because the loss of blood will be very significant, and usually chances of survival may be increased if this occurred in hospital setting or very close to the healthcare institution where repair may be performed. But otherwise, if this happened at home or in the field, the chances of survival very low. Coronary artery disease is a consequence of arteriosclerosis, and may be in one of the most devastating diseases, and it's the single leading cause of death in the United States. It's not the worldwide leading cause of death. Atherosclerosis will lead to narrowing of arteries that supply the blood to myocardium, and if atherosclerotic plaque ruptures, it may lead to inflammatory response and development of the platelet plug and ischemia and infarction. So this is a very simplistic way to describe it. However, again, the main reason of why we are so concerned about it, it's the myocardial infarction, not just we care that how wide or narrow arteries is, as long as they can supply blood to myocardium. On the other hand, sudden decrease of the blood supply to myocardium may certainly lead to devastating consequences such as infarction and necrosis and death. The progressive narrowing of vessels will lead to ischemia of heart muscles and symptoms. And when we're talking about this, we need to learn to distinguish between stable and unstable angina or angina. Stable when we see a pattern of repeating symptoms, such as patient may experience chest pain with walking certain amount of time or a certain distance, and which is relieved by rest or nitroglycerin. Unstable angina is when usual interventions that lead to relief of the symptom don't work. Let's say patient does take his 2 nitroglycerins and there is no relief. Of course, the unstable angina is medical emergency. EMS has to be called, or within hospital setting, appropriate protocol should be initiated. So occlusion may progress slowly or suddenly, secondary to thrombus or embolus. Basically, occlusion may occur when the plaque ruptures and the thrombus developed, platelet plug developed, and the blood supply will be discontinued immediately. When we see a slow progression, this may not be such a big danger for the patient, or it still needs to be addressed, but patient may develop a accessory vascular system which will be supplying blood to and creating a natural bypass. Again, rupture of the plaque may be prevented, and also the development of the plaque may be prevented, A, by lifestyle, B, by including the anti-cholesterol drugs such as statin. Statins, although you read in literature many reports which are somewhat controversial, and that may lead to side effects such as muscle pain, weakness. On the other hand, statins not only prevent the increase in the size of plaque, but also they stabilize existing plaque. So it's relatively rare that patient, and of course this can occur, but it's relatively rare when patient is on statin drug, they have myocardial infarction, because statins have stabilizing properties and also anti-inflammatory properties. Myocardial infarction, when the supply is suddenly decreased or stopped of blood, and myocardial tissue infarcted. Diagnosis will be by history, EKG, and angiograms. EKG or ECG, different places you'll see EKG. EKG is an old way of writing, and the correct word ECG, but you will see some providers will write EKG. Laboratory workup will include cardiac enzymes such as troponin and CKMB. And again, you need to remember that troponin, at least in the context of this text and this course, is a cardiac specific. CKMB may signify other diseases such as diseases of damage to skeletal muscles such as rhabdomyolysis. And treatment will include revascularization, will create, we can do CABG surgery or CABG. Some people have a real hard time saying CABG regarding heart, and you need to say CABG, or you can try to revascularize them by cardiac cath and angioplasty, trying to compress the existing plaque or trying to put a stent. Just a couple of words about healthcare costs. Of course, CABG surgery is a state-of-the-art surgery, but it's very expensive. Cardiac catheterization is one of the innovations that replacing the CABG surgery for some patients, and the cost is, of course, it's much lower. So we see in these cases that innovation will be introduced in healthcare and will be overall contributing to reduction of the cost. So let's talk about treatment in more details. Angina or angina treated with vasodilators such as nitroglycerin, and stable angina is not, of course, what you want to see in your patients, but if it's managed with nitroglycerin, you may opt for that option. If there are no other options, let's say patient's age or other comorbidities doesn't allow for patient to undergo bypass graft surgery, and angioplasty is again less invasive option versus CABG, and may be introduced by cardiac cath. Coronary artery bypass surgery is a significant intervention, and of course, we know that thousands of them done a year in even here in Asheville area, and we have a great facility right next door. However, it's still a major surgery and major risk factor for the patient, a major recovery time and disability, at least for some time for the patient. So what I'm trying to say, when you practice, try to advertise or do propaganda, call it the way you want to introduce these three things here on this list: diet, exercise, and the reduction of smoking. These are three important contributing factors that may make it or break it, and they may reduce the risk of adverse effects of the disease. This introduction of proper diet, exercise regimen, and elimination of smoking can significantly reduce the healthcare costs and healthcare. And let's forget about the cost, but you truly don't want, as a healthcare provider or nurse educator or a nurse or physician assistant, I don't know, dentist, your patient undergoing major surgery. You want to prevent it, and prevention is really truly cheap. So elimination of the high calorie diet, reduction of the calories, exercise regimen, and again reduction of smoking. For some reason, the efforts to decrease smoking were dying last few years. Of course, we don't have TV advertising of smoking, but we still see it in magazines. We still see colorful cigarette packaging. We still see teenagers and preteens, even some places, smoking as well as using tobacco, which to me, living in 21st century, it's truly unacceptable. So try to use prevention in your interventions, and believe me, if you spend time, there are numerous studies done, if you spend time on prevention measures, you will be rewarded, and morbidity among your patients will be reduced. Deep vein thrombosis is one of the topics you are very familiar with, and just to refresh the mind, thrombus is a clot that sits and doesn't move. Embolus is a clot that already moves and travels and can go to other places like brain and heart. To treat this, you may elect to give heparin to reduce the size of the clot, or in which can be regular heparin or low weight heparin such as Lovenox in this case. And prevention, always the key. If patient is under the risk, you may elect to give low weight heparin, as well as use sequential compression devices in lower extremities to prevent this. Next, I would like to talk about it's the rheumatic heart disease and the damage it can cause. Rheumatic heart disease is a sequela of streptococcal throat infection. That's why we are so concerned with doing strep A testing in patients who present with laryngopharyngitis or pharyngitis to define and eliminate the streptococcus A. However, even with the best testing technique, there is a chance that streptococcus A won't be identified, even patient has the actual infection. So in case if you clinically believe that a patient has strep A, you may opt for treating it with antibiotics, and I know this goes against what I was saying before, try to give it a time, but strep A needs to be treated right away. You do not have waiting time. You cannot give 1 week wait and see if it's a viral infection that may be cleared out. Usually strep A has significant appearance in pharyngeal appearance, and you may be even clinically able to diagnose it. So the sequela is developing rheumatic fever, and as a consequence of rheumatic fever, where the valves can be affected. All layers of the heart, endocardium, myocardium, and epicardium may be affected. However, the main concern is valvular deformities secondary to this, and valvular disease. Treatment, again, will include prevention treatment of streptococcal infection, and if patient develops rheumatic fever, of course it has to be addressed, and one of the simplest things to do is rest during the acute stage, and if some valvular damage done, it's valvular replacement or valvular plasty, with just working on affected valve and trying to correct it. But again, important point here is the prevention and treatment of streptococcal infection. And again, if there is a suspicion, even with negative tests, I would suggest to treat it, especially. And in this case, if let's say there is a history of documented exposure, let's say you have 2 children coming to you and you work as a pediatric nurse practitioner, and one of the siblings, 2 siblings, is affected with strep A with positive test, the other not, maybe reasonable will be just to treat both if they look clinically similar. Of course, every case is different, and it's hard to make in a lecture like this hypothetical recommendations, but again, the prevention is the main, and treatment of strep infection is the key to avoid rheumatic heart disease. Congestive heart failure, you are very familiar with this in undergraduate curriculum, but the key point is that the heart fails to pump blood adequately, and it's increase of the workload of the heart, and heart slowly will get thickened secondary to increased workload. The myocardium may get thickened, and symptoms may include the gradual increase in dyspnea, patient not tolerating the walks, tachycardia, tachypnea. Also, another hallmark of this is paroxysmal nocturnal dyspnea, or PND. And you need to know that the paroxysmal nocturnal dyspnea is sudden waking up short of breath in the middle of the night, PND. Congestive heart failure will also result in neck vein distensions, edema in ankles and lower legs, pulmonary edema, right-sided versus left-sided will have, of course, the different manifestation of the edema. If the right-sided heart isn't functioning well, then edema will be, of course, peripheral. Left-sided will result in pulmonary edema. You often will see combined right-left-sided failure, and patient may present with edema peripherally as well as edema in pulmonary system. Diagnosis by history and physical, chest X-ray and EKG. And chest X-ray will reveal increased size of the heart. So how you can decrease the workload? Of course, decreasing the workload may be done by reducing the vascular volume and by introduction of diuretics. Another important introduction here is to introduce low salt diet, 2 grams or less of salt, and fluid restriction. Cardiotonics such as digitalis or digoxin can strengthen cardiac muscle and strengthen the contraction, so they would help the heart to pump more effectively. But again, here the diet may play a significant role. 2 grams of salt is one of the important things you can do for your patient, but however, everything has salt nowadays, and restricting the salt is very difficult. You need to teach your patient to read the labels and calculate. Less than 2 grams will become very difficult task, but still possible. And reducing the salt may significantly decrease vascular volume and decrease the workload on the heart. Cardiomyopathies are diseases of the heart muscle. There will be what happen, the heart muscle for one or the other reason become dilated, enlarged, and thin, flabby. There is no cure per se, and it may certainly lead to myocardial infarction, congestive heart failure, and death. Carditis is an umbrella term for pericarditis, myocarditis, and endocarditis. Depending on the onset of the place, it gets its name. Pericarditis, pericardial sac, may be occurring and causing constrictive pericarditis, and it will be consequence of some type of infection and affecting the pericardium. Often there is an introduction through some kind of window, by window I mean respiratory, urinary tract, or skin infection, will introduce offending agent to the heart and would cause inflammation or infection. Treatment for all types of carditis fairly the same: antibiotics, analgesics, and antipyretics. So the diagnosis can be done by imaging studies, ultrasound, and introduction of antibiotics most likely may resolve the disease. The pericarditis may have the pain in in chest area, have significant chest area pain. However, positional changes may alleviate the pain. So when we comparing this with myocardial infarction pain is not modifiable by positional changing or pressing on the chest area. It has life of its own. But pericarditis pain, again, this is a good test question on the board or anywhere else. So pericarditis pain, you may modify it by positional changes, and while myocardial infarction you cannot. Valvular heart disease may be a consequence of rheumatic fever as well as endocarditis, because when endocardial lining inflamed, the deformities of the valves may occur. And the main point of this slide is to tell you that diagnostically you may diagnose this by auscultation, and you will hear murmurs of types. And murmurs are the swooshing sound when the heart valves close not completely, or there is a stenosis of the valve, then you may hear a murmur. Arrhythmias, abnormal heart rhythms, and I do not want to spend in here long time on arrhythmias because it's certainly a separate part of cardiology, but arrhythmias can be abnormal. Arrhythmia is always abnormal, but some of them can be fairly benign, while others are such as ventricular fibrillation can be deadly. So arrhythmias should be diagnosed and treated, and whatever the treatment is it medications or even using the defibrillator, but still it has to be treated. And defibrillators may be implanted to deal with life-threatening arrhythmias, and this is very generalized coverage of the topic, but at this point, considering so much time was spent on this in undergraduate studies, I do not want to burden you with this topic again. And most of you are working to some extent in, not most of you, but some of you work in cardiology, so this will be truly a rerun of the information you already know. So, but the generalized way to say flutters or increase in heart rate, maybe atrial flutters versus atrial fibrillation. Flutters still may be some kind of pattern be noticed, and you can see up to 350 beats per minute. When you see heart blocks, it's an interruption in conduction system. Heart blocks may have fairly regular pattern, and while flutters are very irregular, and fibrillations on the other hand, it's completely irregular pattern. So atrial fibrillation, the way to describe it will be, when you describe it, you can say irregularly irregular. Heart blocks will be regularly irregular. Then the heart blocks can be first degree, second degree, AV block, or bundle branch block, different type of heart blocks. But again, considering the limitations of the time, I will not be describing each one separately. And here again, first, second, third degrees, premature contractions, atrial or ventricular. So treatment may include, what are the treatment? Treatment may include the medication as well as implantation of pacemaker defibrillator, depending on the arrhythmia.